Welcome to Advanced Nurses. We connect with nurses who inspire other nurses by sharing their experiences. And so we're able to bring that information to you. Hi, I am the education consultant with ACD-10 and I'm here with the coding nurse.
Okay, first of all, it's a pleasure to be here, and thank you for having me. A little bit about my background. I have been an LPN for 31 years, and in 2014, I had left the bedside before 2014, but in 2014, I was able to find a job in risk adjustment. And my first job only trained nurses, RNs and LPNs, and they trained us to be risk adjustment auditors and learned a whole lot. And first, I didn't really take it seriously. I was like, okay, it's just something to do, and I was going to just stick my toe into it. But about maybe 8, 9 months in, I was really hooked. And that just started my quest to learn more and more about the revenue cycle, because as nurses, your nursing education doesn't talk at all about revenue. So you have no idea what part, even as a nurse, you play in a revenue cycle, let alone how your clinical knowledge can be used in the revenue cycle away from the bedside. So that just led me to want to learn more and more and more. And I started in 2014. I got certified. The first coding credential I got was the CRC in 2017. And from there, I just learned more and more because I had to get certified in order to get another job. And I did ultimately leave my first job in 2018 after 4.5 years. And I just started moving up. And in outpatient, I did auditing for an insurance company. I did outpatient CDI for a chronic kidney disease care management company. Then I ultimately moved into inpatient CDI, and I just learned a whole lot more. And all that time, like during the pandemic, I created my company, the Coding Nurse LLC, because I knew that there were nurses like me who wanted to leave the bedside but had no idea how to do it or even what area they should move into. So it's just been a journey. I have an ICD-10 CM class forming Wednesday, August 13th. And I have classes like basically like every other month, pending interest and enrollment. So if anybody's interested, just visit my website, thecodingnurse.com, to see my offerings and reach out to me if you're interested.
That is awesome. So what is your personal strategy around and what you've been using over the years to be a boundary architect and communicator?
I think that as a nurse, like the one thing that is helpful is, in nursing school, like they teach you from day one, and especially when you start working, everything you do is to protect your license. And you have to keep that same mindset when you start to acquire coding credentials, because and even like HIM credentials like CDIP, CCDS, because with every HIM credential, be it, an HIM credential or coding, there's a code of ethics. And the code of ethics is there for a reason, because you really have to adhere to it, because there will be people who will indirectly ask you to kind of skirt the line. And that's why you have to be very clear, because the code of ethics will help you establish your boundaries.
I have to agree with that because especially if you're working in a capacity where you don't have a lot of team members who have your expertise and your knowledge, and you can be called on sometimes to really take out a lot of fires, and you're like, while this may be very important, this is not what you hired me for. And that can be a difficult conversation if you are relying on those boundaries to be set by your management. That is really something that you have to establish. It's important for you to just politely but firmly reiterate those boundaries. I'd like to start off sometimes emails. First of all, hey, always make sure that whatever you communicate is in writing. I think that people tend to behave a lot better when they see something in writing than if they're saying, oh, let's just hop on a call and let's just hop on the teams, or let's just hop on what is this other one? All the ones, right? The Zooms, the Teams, WebEx. Let's just jump on a call real quick. If you're jumping on a call, follow up that call with a summary of the discussion so you can hold that manager, whomever, accountable for whatever you discuss, because you should be falling back to those firm boundaries. Those boundaries actually need to be set before reacting to a request that makes you feel uncomfortable is something you'll have to learn to do. But I think it's so much better when you have those boundaries set beforehand, because you can always go back to those things that leadership or management, whoever, agreed to from the beginning. You could always go back to say, per our prior conversation, as you may know, or as previously discussed. I think that's a great way to frame emails or anything where you really trying to remind them of those boundaries that you previously discussed. And again, you could be polite yet firm, right? Also, master data-driven advocacy. So track your time, your work, and the time that you dedicate to your work quantitatively. Log your times per charts and the query volume and response rates. These are ways that you keep yourself honest about how long it takes you to do your work. And you can also present this to your leadership when questions come about around productivity. In CDI, there are many times where you will be asked about, it's kind of an uncomfortable conversation to a certain degree too, depending on your leadership structure. If your leadership is also if they're certified in coding, if they're certified CDI, they have years of experience, not just a certification, but actually years of experience. It's an easier conversation because for the most part, many of them understand what it takes to do the work. But in many cases, you may be working in departments and under leadership that don't have that experience. And so therefore, when you quantify your time, you are showing clearly, this is how long it takes to do X, Y, and Z. Right? And then when you quantify that time, using things like spreadsheets to report on that time, and again, be realistic about it, but also just have it as a way of keeping yourself honest around how long it takes you to do work. This also helps when you want to set boundaries and also put time on your calendar. I think that's a big thing too. Sometimes you actually need to block the calendar off so people are not popping in with little calls and little requests in between, because they know that this is the time that you already have blocked out to do your work. But what's your thoughts around that, around tracking your work or quantifying the work, your outputs?
Um, Anytime you work in CDI, well, most places, especially inpatient, but even outpatient, they will track your productivity. They have their own like KPIs that they keep track of, like your query rates, like how many charts you do per day, because your manager will have access to all of that information that they get, that they can look up in real time. So the thing that I think that most people need to understand when you start working in CDI is time management, because depending on whether you work inpatient or outpatient, it may take you longer to do a chart review inpatient because there may be a lot going on with that particular patient. And I know like the busiest days for inpatient CDI is Mondays and Fridays, because like those are the days where you have to review everybody that you have in your work queue, all of the cases that you're assigned to, because on Friday you want to make sure everything is as tied up as you possibly can, because a lot of people get discharged Friday evening or even over the weekend So you don't want to have like any kind of outstanding queries. Um, and even then, even on Monday, when you come in on Monday, you have to look at all those people that were there on Friday that weren't discharged, because you have 2 days that you haven't reviewed. Plus, you have a whole full work queue on Monday for all the people who have been admitted from Friday evening all the way till from Sunday night. So, time management is important. You have to know how to prioritize what's important, like in a review. So on Mondays, well, in your daily workflow, you always start with the new work queue, with the new admissions. And on Monday, they're always like 3, sometimes 4 day lengths of stay, because somebody could have been admitted on Thursday, but their file doesn't make it into the queue until after Friday evening. So you could have, like, I've had a 4 or 5 day length of stay on Monday. So on Mondays, you cannot go through a 4 day review. So you have to learn how to, and I had to learn how to, you have to pick out the key points to establish why that person is there, just to figure it out, just to get that particular case out of the queue. Then you reschedule a review for the next day and you do a deeper dive, because your re-reviews should only be like on a Monday, like a 2 day. So if you already know what's going on with your patients, it's not really that hard. Like, you already know this person could be waiting for placement and is in a SNF, or this person could be, waiting for them to get home care set up before they go home. So they're pretty much stable for the most part. The people who are in your concurrent queue. So it's just knowing those little things, knowing like when to send a query. Like, if you know that, if you read the case management note and they're talking about discharge, or if you know that they're talking about seeking authorization for long-term care or for a SNF, that you have to, if there's anything that you need clarified by the attending, you need to be getting that out sooner rather than later, so you can have an answer before the person is discharged.
This is all very good points you made here, and this also just highlights again all of the different nuances in the work that you do that may not necessarily seem very apparent, because again, if all of it seemed like, oh, just chart reviews and provider education or queries, again, all of this may seem like, okay, all of this is happening, and I'm going to have friendly technology that's just going to make this process smooth. It could be messy as hell. It could take forever to get responses back. There could be poor policies around response rates, or when to escalate with providers who are not responding. Also, technology. Things happen with technology, and so a lot of times what you have to consider is, again, going back to even the first point I was making, or the prior point rather, is you have to be really on top of and honest with how much time it takes to do different parts of your job. And so with that being said, when you have those uncomfortable conversations about your productivity or numbers, charts, these are all things you'll be able to demonstrate with the support of data if you are tracking your information, which means maybe they will have a spreadsheet, maybe they'll have systems that's capturing what they need and what they want. That doesn't mean that you shouldn't have your own reports running on the side. Open you up a spreadsheet. It ain't got to be cute. Have the columns, clearly outlined. Have whatever, have your roles clearly outlined. If it's a time-based data that you're doing, maybe you have a workbook and there's different sheets that are dedicated to different parts of your job. Just because the company has not identified areas of your work that needs to be tracked or quantified doesn't mean that you shouldn't be doing that. Because again, if you're ever in your one-to-one, which you're going to be on some type of one-to-one, you're going to have something like that where you're going to be on some regular cadence meeting with your manager or leadership, whomever. You want to be able to show those things to them, this is the work that I'm doing. This is how I'm staying productive. This is what I'm doing when, if we have downtime, like the system goes down, here's my alternative, work queue, whatever. All of these things are very important, again, because not all CDI is the same, right? Not all CDI is the same. We may be solving similar problems. We may use a lot of the similar approaches. Of course, a lot of the language is the same, but no two departments, no two organizations are the same. And so, therefore, you have to have systems in place to quantify and also to use that data in many times to demonstrate, hey, listen, I need to delegate some of this work to someone else. Maybe the department is growing. So initially you had a lot of time to do certain things, but then as the department start growing, you need to start delegating to other departments, or maybe push something back to management. Like, I don't know who is going to do this, but I just know I can't do it. If you are quantifying your time, you're reporting and monitoring your time, you're able to show those spreadsheets and those different reports to say, hey, this is where my time has really been focused. This is the benefits that has come out of me focusing my time in here. This is going to stop me. These activities or this other ask or these responsibilities that I used to have interrupting this, and this is how it's going to, ultimately impact us. But again, you have to be comfortable with making data-driven decisions, and that happens when you're monitoring the numbers. Okay.
I wanted to
So
make
call. Oh, sure. Please.
2 points because when you were talking about tracking, like you had mentioned spreadsheets, like I'm old fashioned. Like I used to well, first of all, like we used Epic for inpatient. So I would make my notes. There is something in Epic and 3M, but I would put my notes in 3M. There's an add finding button for it, when you pull up your case where you look at the codes that have been assigned or that you assign. So I would put in a detailed explanation about what was going on, like what I reviewed, but every patient that I saw or that I added to my work queue, I would have a regular spiral notebook, 100-page, 250-page, whatever. I had stacks of them, and every day, every case I was assigned, I would write the day they were admitted, the day I started the review, their DRG, their primary diagnosis, if there was a procedure, their primary procedure, and anything, like if I sent a query, I would write down the date, because I would need to know that you have to follow up in a certain amount of time if they haven't gotten back to you, because like you said, anything can happen. And if you can't get access, you at least have your own records. And it would also help me because there are glitches. And you're like, wait a minute, I know I was assigned this person. I can't find their chart in the system. So you have their medical record number, so you can put it in and find out what's going on. Sometimes, it very rarely it happens, but sometimes somebody else will go in, another CDI, and not pay attention and take the case and assign it to themselves. And it's like, wait a minute, what is going on? So if you have to keep your own records to keep your workflow straight.
Yep. I think that as you were speaking, my wheels were turning because I was just thinking about all the other ways that someone can access your work. And in a lot of cases, the work that you're working on could be accessible to someone else. And so therefore, that's a really big one, because you never want to be working on something and all that work is kind of lost when you're not tracking it, because you're relying solely on the systems that the organization has provided you. So always have a way of keeping track of your work, your productivity, your own numbers, and you can be able to speak to that, especially when you're advocating for yourself. So cultivate external validation and support networks. So seek industry benchmarks. Connect with CDI professionals outside of your organization. So there are a few ways that you can do this. One call out I would definitely say is the coding nurse and myself. We both have extended ourselves, especially to nurses, the coding nurse, through his courses. Both of us also both offer consultations if nurses are interested in kind of having that sit down conversation where we kind of go through what their goals are. I know before I go into any work with a nurse, I try to make sure that I'm very clear on what they're expecting. And I'm very clear to them where my boundaries and my limitations are. The coding nurse doesn't have as many limitations as myself because he's been doing this work for years. And so therefore, reaching out to CDI professionals is really, really important. Don't try to go navigate this by yourself. You'll be wasting a lot of time, a lot of energy, and a lot of times you'll be misdirected by people who are probably looking to gain something for themselves. So there are people out here on YouTube that have no problem, on YouTube, LinkedIn, everywhere. They Instagram, TikTok, they don't really care about misdirecting you, because if at the end of the day your money ends up in their bank account, that's fine for them. But we don't want to send you down that pathway. So it's so important for you to connect with CDI professionals. I also would say, more importantly, if you are certified, you won't have an option in this part of it, but your local chapters is a really good place for you to network and meet with people who are in a similar situation. For example, in many cases, they may actually have some overlap with some of the practices. If you are in the same region and you're working in the same hospital systems, you can talk to each other about kind of like navigating certain systems. Also, your CEUs, when you become certified, a part of maintaining your certifications is you having those local chapter meetings. And there's so much information that comes out of those meetings, especially if you're working in a capacity where there's just a very small team of CDI professionals that you're working with. You're lucky if you're working alongside coders, because then you could definitely tap into their knowledge. But if you are trying to navigate this and you're in a small team of CDI professionals, the opportunities that you get to learn from your local chapter meetings are just, I can't even express how important that is. And that's one of the reasons why I want to shout out AAPC for that, because AAPC mandates that you have that. Now, I don't know if they're going to change their mind later on, but this is what the case is right now. So it's like they figured, it's almost like when your mom tells you to do something and you don't really know why she told you to do it, but then later on something happens and you're like, oh, that's why mama said that. Like, I'll give you a little joke. My mama got this thing where she always says things like, old school, never leave your house without a pair of clean underwear in your bag. And her mind is like, and then back in the day when people would when we used to have the payphone, she'd always say, never leave the house with enough, without enough money to make a few calls on the payphone. So that back in the day, that's way back in the day, right? Nobody wants payphones now. I don't even know if they exist except for nostalgia reasons or, some type of historical context, some, I guess, visual thing, whatever. But yeah, there were a time where telephones were all over the place and you could put a quarter or two in there. My mother was very big on have enough money in your pocket to make a few calls like that. And so you don't realize it until your emergency, those words come right back to you. So when AAPC says, you have to be a part of a local chapter, AAPC is saying, I know what's good for you. You know what I mean? And so therefore you don't get this paperwork and you're sent out, with a little pat on the head and a pat on the tush and say, good luck. They're telling you, be connected to a community. Yes. I want to hear what you have to say about that.
The only thing that I wish I would have done sooner was join an organization, because it is a missed opportunity to wait until you are certified or you're about to test for certification to join an organization. And both AAPC and AHIMA make it very easy. As long as you are not certified, you can sign up as a student member to both organizations. And I know AHIMA is $25. I think AAPC is somewhere around there too. And networking cannot be stated enough. And the best way to network is in these organizations, and initially through your local chapters. And once you are a member, you can then reach out to other chapters. You don't have to just be limited to your chapter. And you can always change your chapter. You don't have to be assigned to a geographic location. You pick your chapter. And on AHIMA side, they call it state organization or component organization. So you can pick that. And I would tell anybody, if you're thinking about getting into HIM in any capacity, join Start with your local AAPC or your state chapter for AHIMA and go to the meetings, introduce yourself, tell people what it is you want to do, and then solicit advice. And you will be surprised how many people are willing to lend you their experience to help you.
Yes, I would have to say that's really true. Just be clear and honest about what it is that you're looking for. I know sometimes, especially with nurses, it may be really difficult because of the fact that you come in with so much information and you may actually have misconception about what it is. I don't even know if I use that word correctly. That's the word to use, but you may have a misunderstanding of what you really need from that chapter, or you really need from the networking opportunity. And so therefore it's like, I have all this knowledge, what can I really be asking them? So what you really want to just be honest with yourself is about what you don't know about coding, right? And what you really don't know about provider education. And and what for example, what am I looking at in the chart review? It's very different when you're looking for something like you want to validate, or you're looking to see that someone received a service that was previously ordered. I know in case management, that's something that we do all the time. We always look at records to make sure that whatever was ordered, the person received it, they're responding well to the treatment. If they have not received it, you start investigating why they haven't received it. And that's really the work, case managers do every day. But that's a very different reason than looking in the chart when you're doing a chart review. All of it, 100% of it is grounded in the guidelines. So the gem that I want to really put out there today is, if you're interested in CDI, a great place to start is learning about the guidelines, whether that is watching videos. Again, you have to be very careful about that. I would say the best place to start is like where I started with the coding nurse. But you want to familiarize yourself with guidelines. You want to put yourself in the best position for you to master the guidelines. And something I said in a previous video that I did just a week or so ago is really try to figure out if they're like five, I wouldn't say even go as much as 10, 5 conditions that you commonly see within the work that you do. And really try to understand the guidelines related to those 5 conditions, so that you can really start thinking about how it impacts everything. I would say it's too ambitious to look across everything, but one of the first steps I would say is really get you like common conditions like CHF, like diabetes, like CKD, like COPD. Like look at those conditions and really, diabetes, if I didn't call that out, look at those conditions and look at some of the guidelines around those conditions, because those are chronic conditions that are so common. Those are really opportunities for you to kind of get your, like build a foundation around the guidelines and mastery of those guidelines. Is there anything you wanted to add about that? 'Cause I know you were very big on the on guidelines, because that's essentially something I learned from you.
I think that for most people who enter CDI, because most nurses who enter CDI, a they go right into an orientation program um, at whatever organization, and they don't really they kind of, it's sad, but they don't really focus on coding the way that they should. They focus on what they call in inpatient DRGs, which are diagnostic related groups. But the diagnostic related groups are based off of ICD-10 CM, which is the diagnosis or disease code set, and or ICD-10 PCS, which is the inpatient procedure code set. Either way, medical coding is involved in assigning the codes that will get you to the correct DRG. And the guideline you will use guide in CDI, you will use guidelines all day, every single day. You cannot get away from it. And the sooner you begin to learn and begin to become comfortable with and master the guidelines, the easier your job will become, the more proficient you will become, and the better you will become at CDI.
Here's more about the coding nurses' medical coding and CDI training services.
CM training, it is an 8-week course. We meet twice weekly in the evening for 8 weeks, and then I'll also offer ICD-10 PCS training. And in order to take the ICD-10 PCS training, you either have to take my ICD-10 CM course or you have to pass an ICD-10 CM assessment that I give you before you can go into PCS. And PCS is 6 weeks, and it is also twice weekly for 2 hours in the evening.
We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.